Thank you for taking the time to join us today. I'm Julia Hume, the Executive Director, Costing and Data Infrastructure at the Independent Hospital Pricing Authority. I would like to acknowledge the traditional custodians of the many lands on which we are meeting on today. For me, it's the Gadigal people of the Eora Nation, and I recognise their continuing connection to land, water and culture. I pay respects to elders today and those who walk in spirit. It is my pleasure to welcome you to the final session in the Q&A webinar series that we have held over the past year. It's been an incredibly rewarding experience for us to connect with you about the issues that matter most to your field of work and bring together industry experts that are able to speak to the broad range of perspectives that contribute to the delivery of high quality healthcare services. The goal of this series was to build on the knowledge in the sector of how public hospitals are funded in Australia through activity-based funding by covering each of the core functions that enable IPA to develop its pricing in order to continue to drive improvements in this work. This has included sessions on policy and classification development, costing, data collection and pricing. With all of this background behind us, we are eager to host a discussion on where this work is heading in today's session, Funding for the Future, Investigating and Implementing Innovative Funding Models in Australia. With the recent release of the consultation paper on the pricing framework for Australian Public Hospital Services 2023 to 2024, in which IPA sets out its intentions to investigate trialling innovative models of care, this afternoon's webinar is particularly timely. We are eager to engage with you to explore the development and implementation of new funding approaches and hope that the case study on a trial of value-based funding undertaken by Genesis Care in Western Australia for early stage breast cancer patients that will be the basis of this discussion will be valuable in understanding the opportunities to improve continuity of care. Our moderator, Dr. Sarah Neville, will introduce our panel shortly. If you have joined us for an earlier session in the series, you would know that we jump straight into the discussion and encourage you to submit questions in the Q&A panel. And I know that our panel will do their best to get through as many in the hour that we have available together. I look forward to following the discussion. Now, to introduce our moderator, Dr. Sarah Neville. Dr. Neville is IPA's Director, Analytics, and the 2022-23 Harkness Fellow in Healthcare Policy and Practice. Dr. Sarah Neville is a statistician with a strong interest in health, research and leadership. She has been working within the Australian health system for 7 years, helping to set the price of hospital services in order to make hospital funding more transparent and equitable. Sarah holds a PhD in mathematical statistics and is passionate about the power of statistics to inform evidence-based policy in Australia and internationally. Before I pass over to Sarah, I would like to remind you that all webinar recordings are available for you to watch on IPA's YouTube channel. While this is the last session in the series, IPA will continue to host discussions like these in the future. And the best way to be notified of upcoming events is to subscribe to our mailing list, which you can do so via the IPA website. I hope you enjoyed today's Q&A. Thank you, Sarah.
Thanks, Julia, and good afternoon, everyone. Welcome to the final webinar in our series. I'd like to welcome everyone joining us and open the session today by introducing our panelists. Panelists, if you could just raise your hand as I introduce you so everyone's aware of who you are. So first of all, joining us today is Professor Kees van Gool, IPA's Executive Director of Pricing and Analytics. Kees is a health economist with extensive experience in national and regional health policy research. In addition to his role at IPA, he leads the National Health and Medical Research Council's Centre of Research Excellence on Value-Based Payments in Cancer Care. Very relevant for today. Keys's previous roles include Deputy Director at the Centre for Health Economics Research and Evaluation, or SHARE, at the University of Technology, Sydney, as well as Health Policy Analyst at the OECD. Welcome, Keys. Next up, we have Professor Christabel Saunders, AO. Professor Saunders is the Head of Department of Surgery, University of Melbourne, Consultant Surgeon, Department of General Surgery, the Royal Melbourne Hospital and Peter Mac Cancer Institute, and James Stewart, Chair of Surgery at the Royal Melbourne Hospital. Professor Saunders brings a wealth of experience to the panel today. She's a member of the Medicare Review Advisory Committee and past president of the Cancer Council Western Australia and Breast Surgical Society of Australia and New Zealand. Professor Saunders is internationally recognised as one of Australia's most prominent research-oriented cancer surgeons. She has substantially contributed to breast cancer research, including clinical trials of new treatments and psychosocial, translational and health services research. Professor Saunders is Vice President of Allcan International and member of the boards of Allcan Australia, Breast Cancer Trials, the Australian Centre for Value-Based Healthcare, and PathWest. She's also a member of the Medicare Review Advisory Committee and past president of the Cancer Council Western Australia. Welcome, Professor Saunders. Next up, we have Julia Schultz, Vice President Corporate Development at Genesis Care. For the benefit of those who have not yet viewed the introductory presentation, Genesis Care is a provider of cancer and cardiac care services in Australia, the US, the UK, and Spain. Very international. They are currently trialling bundled payments for early stage breast cancer patients in Western Australia with the view to reducing out-of-pocket expenses and optimising cancer care, and this case study will frame our discussion this afternoon. Julia holds a Bachelor of Business Administration and a Bachelor of Health Science Management and Health Services Management, and is due to complete a Master of Public Health, Health Services Management at Queensland University of Technology in 2023. Our final panellist, Dr. Sarah Wise, is a Senior Research Fellow at the Health Policy at UTS's Centre for Health Economics Research and Evaluation. Dr. Wise has over 20 years of applied research and evaluation experience in health, aged care and community services, both in Australia and the UK. Currently, she leads the Policy Observatory of the NHMRC Centre for Excellence on Value-Based Payments in Cancer Care and is an adjunct senior lecturer at St Vincent's Clinical School. I feel like we've got enough experience for quite a few panels with these panelists. Thank you all for sharing your valuable expertise and perspectives on this panel. I'm very much looking forward to facilitating the discussion with each of you today. Before we start, a few brief housekeeping issues for everyone online. To submit a question to our panelists, please click on the live Q&A tab on the right-hand side of your screen. I will direct your questions to the panellist who is most suited to address the topics and issues raised. And if you're interested in knowing the answer to another attendee's question, you can vote for this question by clicking the thumbs up button beside it. With that said, let's get started. While we wait for live questions to come through, I'll start with a few questions that were submitted by attendees before. And I'll direct the first question to Julia. Was genetic testing and/or counselling considered for inclusion in the bundle? Why or why not?
Thank you for this first question. I will partner this answer with Christabel, who will talk about genetic testing and the importance of that. But I will just answer the question as it's asked. So we did consider it. It's not included right now, but we are very much connected with the genetic counselling service in WA, and our patient navigator will be connecting patients, working with our providers and connecting patients to that as and when they would like to access that service. But I will hand over to Christabel to talk a bit more about genetic testing, and then I can circle back and finish off my answer.
So for a woman newly diagnosed with breast cancer to access a Medicare rebate for genetic testing, you need to have at least a 10% chance of having a known germline genetic mutation, things like BRCA1 that you may have heard of, the Angelina Jolie gene. And to work out if that 10% threshold is reached is quite a complicated algorithm that at the moment is largely done by geneticists or genetic counselors, although it can be accessed by any specialist. And so for those patients, that is discussed generally when a patient is diagnosed with cancer in a multidisciplinary meeting. And for those who reach that threshold, they can be referred to public genetic services and get tested for free. But it's a good question because, in fact, there's a lot of move now towards thinking about widening those criteria to test more women. Because we know from a number of work around the world, pieces of work, that if you widen that and you test a much wider variety of women, in fact, there's a study here in Melbourne, we're testing everybody with breast cancer who arrives to see if they have a gene. You will pick up about somewhere around the region of 5% of people who will have a genetic mutation. But though, as you've rightly sort of thought of, that's not at the moment rebated by Medicare, but we do actually have an application into the Medicare review to have a look at that a little bit in a bit more detail. So it's an evolving sort of feast at the moment. So we haven't really got very good guidelines. So we thought we'd just go with the guidelines at the moment, which is available to have it done publicly. The other just very interesting thing, just for your knowledge, is that it's actually pretty easy to do private genetic testing now. And in fact, there's a lot of online genetic testing and there's lots of pros and cons. I won't bore you with the clinical details, but essentially you can spit in a cup, send it to America and get a genetic test result back in 2 weeks for $299 US. So, yeah. So there are, as I say, there are pros and cons to that because not all the tests, they're accurate, but they can come back with things called unclassified variants, which make life a bit difficult. So at the moment we're going with convention, which is Medicare funded, so it doesn't need to be in the bundle so much. But we're looking at that.
Yeah, and I think the great thing, we're going to track all of the services that a patient accesses over the course of the bundle, whether they're in the bundle or not. We're collecting that service usage data throughout the pilot. So we'll be able to see how many patients typically access those services or want to access them. So we can make a decision down the track whether to include it going forward as well.
Great, thank you. All right, next question, and it's more about how we might get some learnings from this trial and apply them in the public sector. So maybe one that Keys could jump in on as well to give the IPA perspective. How does the trial by GenesisCare for private patients contribute to IPA's role in determining the costs for public hospitals? The person who submitted this question is seeking to understand how this case study could be of benefit to a public breast cancer patient in a public hospital and the link between the trial and IPA.
Which one of us would you like to answer first? I can start if you'd like.
Yeah, if you could start, Julia, that would be great.
Sure, no problem. So our plan is we're doing an evaluation of the bundle, which Sarah is leading, and we plan to, as I kind of touched on before, collect the service usage data and outcome measures, cost data, and get a full view of the patient's experiences and outcomes, and compare that against patients that don't access the bundle. And so although it is in the private sector, we will get a really good view of service usage and costs for patients. And we do believe that this will be quite valuable for the broader industry in terms of understanding patient pathways, the true cost, the experiences that garners from patients as they go through it. And that may lead to potentially reviewing the way that services are provided in both public and private sectors as well. Hand over to Keys or Christabel or Sarah to add to my answer.
No, I totally agree. And so from IPA's perspective, I think what's really interesting about the pilot and what's being proposed here is that that distinction between public and private really starts to blur once a patient leaves a hospital. And so what I think is truly unique about what Genesis Care and WA and UTS are doing is they're looking at it from the patient's perspective and the treatment perspective rather than the funding and the sectoral perspective that is usually taken in these matters. And so all of a sudden, we are actually integrating and looking at it as a whole treatment pathway rather than where each part of the treatment is located. And that of course has enormous implications and lessons for IPA in terms of once a patient leaves a public hospital.
And can I add to that, Keys? I think it's given us already enormous insights into that pathway of care. Lots of things that you wouldn't even imagine, the patient needs, you don't always think about, and how much they cost, and which are necessary and which aren't. And if we can link that to the outcomes that we're measuring, including patient-reported outcomes, I think that will be a really valuable lesson for us all. And then, of course, I also add, we now are increasingly looking at sometimes even outsourcing some of our public hospital work to the private sector, for example, looking at our post-pandemic wait lists and things like that. So, this might be very useful as a model for other diseases, how we might look at packaging up a whole care and working out both the good outcomes for it and how much those cost. So that's the real value of it. Thanks.
Great. Sounds like there's a lot of learnings for the public sector as well as the private. That's great. I'll direct the next question to Sarah. What can you tell us about some of the alternate funding models, such as bundled or capitation payments, that are being used in comparable overseas jurisdictions?
Well, this, as just discussed, this model of care is really the most comprehensive that we have found in the world in terms of trying to really value-based, fully integrated, and a full, complete episode of care rather than the individual treatment parts. So the only other, in the cancer space, the only other bundle payments that we've come across are in America. So there's the oncology care model under the Center for Medicaid and Medicare. I can't remember what the S is for. Yeah, so
innovation.
Yeah, so part of that, and but it's only chemotherapy. They also have a radiology one, but it's only radiology. No one has yet tried to bundle the whole episode up from treatment through to diagnosis through to the sort of all the primary treatments, and include in that all the supportive wraparound care and a patient navigator. So it really is a very comprehensive bundle, and much more so, which is why we're very lucky to be getting such good quality data to be able to evaluate it. Because another thing, as we've tried to do a systematic review of bundle payments, is that the design and the evaluation criteria are very murky. It's very hard for people to make a good assessment about whether the impact that these interventions have had. So yeah, it really is the first in its world. I mean, capitation's obviously very, very different, and that it is comprehensive, but it doesn't have that that very carefully disease-specific designed process. It's probably closer to some of the orthopedic bundles that do have rehab afterwards, but obviously much more complex because we're dealing with a chronic disease. So in terms of an integrated package of care, it really is. There might be some other little pilots around that haven't published yet, but certainly in terms of what's out there, this is pretty world leading.
Great, thank you, Sarah.
And if I can add to that, sorry, I think what's also unique about this is as Sarah mentioned, is the design of this bundle, where where we usually think about the starting point is sort of fee for service in the Australian healthcare system, where a lot of the financial risk sits with the payers, and the payer can be the Commonwealth, it can be private health insurance, could also be the patient. And so there's a financial risk of both the volume, the queue, the quantity of services that are provided, but there's also a price risk. And usually that price risk sits with patients, particularly in the private sector, for private hospitals, but for everyone once you leave the hospital system and you go into the follow-up care after surgery. This bundle approach is unique in that it starts to then share those risks amongst the main players. So it plays around with who actually bears the risk, and a lot of the risk reduction is with the patients, because they know where what their maximum contribution is going to be. Risk is transferred to the providers, which is what usually happens in a bundle payments. Here there is a shared risk between still the payers and the providers. So it's a unique in the element in the design where the risks, the financial risks, are shared from the starting position of fee for service.
Great, thanks for that, Kees. A slight sort of change in focus, and I'll aim this question at Professor Saunders. You mentioned PROMs. How realistic is it to incorporate these into funding models in Australia? And how can we manage resistance or build consensus among the clinical community for these metrics to play a part?
Yeah, well, that's a big task, but one I think we need to start working towards. There is no doubt that we need to get better at collecting the data that matter to patients in order to deliver value care and to get rid of some low value care as well. And so this is a good, and this is how this project started out actually, because we had a larger project in WA, our Kick Cancer project, looking at trying to introduce value-based healthcare generally, which included collecting PROMs. There is lots of barriers, that include the technological ones, that include making sure that we don't overburden patients, that we make those PROMs that we collect understandable and the utility of them ideal, both for the individual patient consultation, but also for the sort of meta level where we're looking at delivery across a service and how it improves. But we have to be able to work towards this. And there's now really strong moves across the world to look at how we can best integrate PROMs. There was a nice paper published only this week in one of the American Cancer Journal, clearly showing that for patients with metastatic breast cancer, weekly collecting electronic PROMs actually improved outcome. They'll actually improve survival. We picking up when things go wrong early for patients will actually improve survival. And so if we can integrate and do that well, in both the public and the private sector, there is no doubt that it will be those institutions that do that which will give the best value care for patients. And that's probably how we should be directing payment models in the future. It's going to be a long haul. Last week we were having a look at the new Medical Cost Finder website, which shows the costs of care for patients in the private sector being developed by the Department of Health. But of course, at the moment, there's no quality indicators on those. So, what do you go to the surgeon who's the most expensive because you think they're the best? Well, until we start collecting PROMs, we'll have no way of knowing really what their quality is. The quality indicators we collect at the moment are fairly gross, mortality, 30-day readmission rate, whatever it is, they're fairly gross kind of quality measures. And to get a finer and deeper understanding of that, we need to collect at least some minimal PROMs. And so doing that as part of this experiment, if you like, as part of this program, I think is really, really important. I'm not saying we've got it right at the moment. I don't know if the PROMs that we're collecting are ultimately going to be the best ones and the easiest way of doing it, but we have to be able to do that.
I think we have been working on reducing some of those because a lot of the question sets that are standard that have been developed, they're very long, because it's always easier to add to a questionnaire than take away. So we have worked on a streamlined version of the ICHOM data set to ease the burden. But certainly talking of sort of been to a fair few sort of discussions and webinars with some of the experts in the US, and a consistent story is actually in terms of clinician buy-in on any of these reforms is really appealing to the desire to improve care and improve patient outcomes. And I think sometimes, especially with the way we approach discussions around funding, is that immediately the hackles go up and say, you're going to, this is going to be used as a stick to beat me with, rather than as an opportunity for improvement in the services. And the value isn't necessarily about technical efficiency, although it will be partly. So yeah, it really is about how you bring people on board and how that the sort of sense of openness and an opportunity for improvement. But it's a challenge for sure.
And maybe I could just add a little promo at the moment, if I may.
Please.
We published this week, Allcan International have published this week a paper on developing efficiency metrics in cancer. So applicable to anywhere in the world. And so if anybody wants to look it up, it's on the Allcan, that's ALL.CAN, Allcan website. And basically there are a list of things that you could measure, either as an institution, a country, a single unit, on are you actually delivering efficient cancer care? And by efficiency, we mean what's best for patients. And part of that will include collection of problems. There are a whole load of other metrics that are useful as well. So if any of you are interested in how we can measure how well we're doing, I think that that's a really interesting piece of work that might be useful for us here in Australia. Thanks.
Great, excellent. Look, and thanks to the audience for sending through so many interesting questions. I'm trying to pick out the ones that have been highly voted. I might direct this one to Julia, and other panelists feel free to jump in if you'd like to contribute. It's quite an interesting one, actually. Can you address cross-subsidisation of services? So health providers care for a whole lot of NDIS patients, for example, with inadequate supports in the community. How can we get the mix right?
I might need a bit more in terms of cross-subsidisation. Do you mean, I guess we've probably done a bit of that in terms of we've looked at, correct, jump in if I'm not answering the question as in the way that you were hoping to get it answered. But in terms of the way we looked at the bundling, we did a lot to make it us able to look at it and at work. We did a lot of sort of weighting of services to be able to create a package that was financially viable for all providers and patients and things. So there is a bit of cross-subsidisation, I guess, to be able to bring the package together. And I think that could be probably applied I think it probably has to be applied as you, if you are the person administering the bundle. But hopefully that's answered your question. But
Julia, can I?
That was a little bit left field.
Maybe,
Yeah.
Julia, I can just, thinking about that, I think what is being suggested is that often healthcare isn't just about health, it's about things that are outside the jurisdiction of the hospital or the clinician to provide, whether that be, as you say, NDIS or disability, aged care, educational. And I agree they can be really important. This package doesn't address those so much, but there are some interesting people around the world who are trying to look at that. And we had our value-based healthcare conference in Perth last May, and one of the most interesting presentations was from the Staten Island Health Group, who presented a way that they're trying to deliver healthcare in Staten Island, but including things like, for example, the judiciary. Many of their patients are heroin addicts and come across the judicial system a lot. So they were within their health packages, they included that kind of thing. There's some other great examples where you integrate aged care or disability services into health. And I completely agree that, you know, health, the social determinants of health are often as important for our outcomes as actual health itself. And I've always been a firm believer, and I think this is directed at governments, that governments should try to work across jurisdictions, and that when we're addressing health issues, it should be across the jurisdictions. And I don't know if I'm allowed to say this online, but I always used to say to our health minister in WA, all the problems that we have with patients, you know, basically they end up in health because, you know, shit flows downhill, and we end up taking all of those social problems as well. But I think if you're going to properly address them, you need a cross jurisdictional system to do that. This bundle clearly isn't doing that for early breast cancer, but it's a bigger question.
And that's where capitation models are more helpful, where you've got a greater flexibility in terms of what's provided. And with the bundle payments, it really is for a defined pathway with a relatively homogenous group of patients. And that's, I believe, Julia, that was why you guys decided to start with this particular group of patients. So you then have to look at, you know, sort of other models of payment reforms that have different, have greater flexibility in them, I suppose, in terms of the services and the actors involved.
That's right. Yeah, we're looking at I guess further down the pathway, but at a very sort of acute area where a patient is sitting. So yeah, the integration with other sectors and things like that isn't so relevant as we're looking at it right now. But you know, down the track we might broaden it out.
But then IPA's got a job on in aged care, because really that's I always say that, I mean, home care packages are essentially a very broad bundle payment, and that really is where we've kind of tried to separate out social care from healthcare, and it hasn't gone well. So that's one of the big challenges for Australia, and that really is, you know, keeping older people out of hospital when they don't need to be, and all those things, all those early interventions, so and early clinical clearance, so signs of deterioration and all those things. So it is happening. It is happening here. It just hasn't come under the banner of innovative payment reform, because it's been sitting over there in aged care.
Yeah. Thanks, Sarah. Another question from the audience, sort of interested in how this all got started. The question is, how did you pitch the bundled payments model to providers? What was the carrot for them to enrol?
Well,
I'm not sure who's best placed to answer this one. Oh, Julia, thank you.
Well, Christabel and I think can do it together. Christabel was there from the very beginning, because I picked it up in the middle, but it was very much a partnership with UWA and Christabel in particular, who was looking at outcomes from patients and their experiences through the work with the AllCan and the Kick Cancer Project as well. And we identified that there's, as well as other industry research that showed that out-of-pocket for patients was rising and only getting more and more difficult for patients to manage. And so the overall view of that was there's got to be something that we can do about that. And that's where we started talking quite closely with Christabel and thinking about how can we make a big difference to patients in terms of their experiences, outcomes and costs. And that's where we got started. So I'll hand over to Christabel to add to that.
Yeah, there were lots of threads, I think, that started it. I mean, you know, credit to Bupa and Zoe Weiner, who was at Bupa at the time, who's now in public health in Victoria. They'd had an interest in it and had worked with an obstetric group who'd done a similar kind of project in a more narrow way. But we also, came out of our patients, you know, so again, back to AllCan, they did a global survey, which I mentioned in the talk, where we asked patients what mattered to them, and they wanted, you know, joined up care, they wanted to have all those supportive services, and they wanted financial transparency. And this seemed a great model to be able to provide that. But I also think the real key was having Genesis come on board, because there is no way that other single providers would be able to take the burden of that. Well, maybe the insurers would, but they weren't willing to, and probably aren't allowed to either, really. So having Genesis as a large provider of care could take that financial risk and burden was really important. But getting people on board wasn't so easy. You have to win the hearts and minds of people and make them believe that, this is for the best for their patients, but that it's not going to cause any financial or administrative burden to them as well.
Yeah, I think as a team, we were talking a bit before this, and practically it was challenging, as most of the Genesis Care team, although we're running the pilot in Perth, we're based in Sydney, and of course the WA border was closed for the majority of the last 12 months. So, and that was when we were in key sort of final design of the bundle. And although we were having lots of Zooms and lots of emails, there's nothing like being face-to-face and really having those discussions to really make everyone feel like they really understand what's going to happen, and feel really engaged and on board and champions of the model. I think we really missed being able to do that during that 12 months.
And then, Julia, I threw a spanner in the works by moving to Melbourne halfway through as well. So I'd been in Perth and got all of my colleagues, as one of the more senior breast surgeons around. I'd got all of my colleagues on board. And then last November, I left Perth and moved to Melbourne, which didn't help. But I think in some ways it's good. If something can't stand without you as a person there, then it's clearly not going to work. So I think that was probably the best thing. And hopefully that'll help as well when we try and roll this out more widely to either other jurisdictions or indeed to other diseases.
Yeah.
Great, thank you. Touching on the last part of that answer about potentially being able to apply this in other areas, what, if any, other diagnoses or treatments are being studied for suitability to be paid via a bundled payment method? For example, are advanced therapeutics, which have multiple cost inputs, in addition to the treatment, such as gene therapies, being considered?
From a Genesis Care point of view, we are just starting with this, and we're starting with this because, working with Christabel and the team, we were able to define a pretty clear pathway for stage 0 to 3 patients, and it sort of lent itself well to building a bundle. We could define the pathway quite clearly with most of the services that a patient would ordinarily require. And so the point of doing a pilot and of having it evaluated is to really understand the ins and outs, what's critical to be able to make a bundle work. And then we certainly will look at extending bundles within Genesis Care in terms of tumour streams, and we hope that the learnings from our bundle as well, from the evaluation, will be able to inform broader industry about how bundles may be applied to other areas.
And from a sort of a criteria perspective of what makes a good opportunity, what creates a good opportunity for funding reform, I think one of the key things is just to have a look at what is the current situation and how is the current funding system imposing barriers to effective and efficient care. And so in the case of cancer care, the fact of what Christabel was mentioning before, and an issue for patients is the lack of transparency and just the complexity that patients face when they are navigating the healthcare system. I think it is incredibly difficult for patients to know what they're up for at each part of their cancer journey, and that then has consequences. That can actually have consequences for the decisions that get made by patients on what they access at a particularly difficult time for them as they face a pretty big health battle, but which also has implications on their incomes. So that sort of dual impact of facing higher cost and at the same time potentially having lower incomes can have real effect on their treatment decisions.
Thanks, Kees. I might keep you going since you jumped in on that one. And this is a slight change of direction. What are IPA's broader ambitions for supporting future innovative funding models? That's our most upvoted question, which I think is reflective of the audience today.
Yeah. So right. So under the National Health Reform Agreement addendum, IPA in alternative funding arrangements. We are there to partner with jurisdictions to look at what can be achieved. And I know that there are discussions between the Commonwealth and between jurisdictions around what areas they could look at for future funding reform, including bundling and capitations. And IPA is there to partner to look at the impact that such bundling, such alternative payment arrangements might have on current arrangements, as well as looking at what data we could provide to help evaluate and look at the impacts of those. So yeah, IPA is essentially, will be and is a designated partner to those discussions that are happening at the jurisdictional level.
Thanks, Kees. Another question that's come through, which is more focused on clinicians' roles in these sorts of bundled models. In taking a truly patient-centred approach, what can I as a clinician learn from this study and how my practice might change through such a funding model?
Shall I make a start on that?
Start with, yeah, that'd be great, Christabel. Thank you.
All right. Well, I mean, if we're being very frank, clearly Genesis are interested in getting good market share of the radiation oncology world. I don't think there's any denial about that. So one of the things, if you have a really good model of care that looks like it's producing great outcomes at a great cost and the patients really like it and understand it, then clearly you're going to get more patients referred to you. I mean, you know, that makes sense. But in order to deserve that, you need to ensure that you are delivering excellent care and that that's proven. So I think, you know, that's a win-win for everybody. In terms of the clinician, signing up to this sort of bundle of care means that you have, for the patient, you have a patient in front of you who has all these advantages of having that navigated care pathway, access to allied healthcare without you know, some of the excess costs that would normally be there. But again, you know, your side of the bargain will be that you either have to guarantee that you're either a no gap provider or a known gap provider, and that is, you know, how you're providing your care, and that you do it within the framework of providing excellent care. Within the bundle, because we can't include everybody, it also means that as a clinician, you will be limited if a patient is in the bundle on who you use as your other providers of care. So, you know, who you refer to the patient for physiotherapy or which medical oncologist you refer to. The good thing about most of us working in an oncology practice is that we already work in pretty tight-knit teams. We already have a multidisciplinary group, patients are discussed. And so we normally work with those other providers of care anyway, so it doesn't make a lot of difference. Of course, if the patient chooses to go to somebody else, they want to go and see a medical oncologist at a completely different hospital on a different site, that's fine. They just are no longer in this bundle of care. So I hope that it will be fairly low impact to the clinicians in terms of, as I say, any administrative burden. We've really tried to ensure that. I hope that it will mean that they will be able to see their good outcomes, and all of us want to, you know, all of us as clinicians want to get the best possible outcomes. We want to deliver high quality care. So this is how you can prove that you're actually doing that. But that there will be, you know, some constraints within that you have to live with, both in terms of how you deliver care within the bundle and how you charge for that care. I think that they're very reasonable and worth taking, but that's something that Sarah's going to be analysing. She's going to be doing interviews with all of the providers and the administrative staff at the end. So we'll get a lot more of a view on that, Sarah, I think, won't we?
Yeah, that's right, and I think it's interesting that it's not just the providers providing treatments that are included, but also the pathology. Because I've also got a small project running at the Kinghorn Cancer Centre in St Vincent, so we're looking specifically at the medications management process. So rather than not so much the MBS, but the sort of how the PBS impacts on fragmented care and difficulties in care. But one of the things that the oncologist said there was that they always try and encourage people to go to a particular pathology lab because they report the results exactly as they need them, and always remember to CC the right people. And people can experience, delays and sort of missed, things not being picked up soon enough because they go to a different path lab and it's completely, either that's not reported in the same way, it's not as full as it was requested. Similar issues with community pharmacy, which I won't go into, but it's creating that network of providers. And yes, cancer is way better than many other sort of areas in terms of that MDT process, but it's still whenever you add somebody new to a team or a different person to a team, it creates a complexity and sort of more potential for sort of misunderstanding and error. So creating a really stable team of providers, including all of those wraparound services and pathology, I think is that sort of next step to providing truly integrated care. And as Keith mentioned earlier, once you're out of hospital, there's very little difference in those complexities, whether you're public or private. And it's really after you've been discharged from hospital that really the value of this bundle really does kick in.
And I think also from the results of the evaluation, we will hopefully really understand what patients value and what gives them the best experience. And so I think that may influence the way that providers refer and what they include in their services and things like that as well. So I think it has quite it has the potential to change the way providers provide care over time.
And the other thing, Julia, is GPs. I mean, if you ask a GP, if they have a patient diagnosed with breast cancer, what do they want? They just want to send the patient to somebody who can sort it all out, and this is providing that. So it will be very interesting to see what our referring GPs think of this as well. I reckon that they'll find it very attractive.
Great. Quick follow-up for you, Sarah, from the audience. It's great that the model is getting evaluated. Any chance that this will be available to read in the future?
Well, yes, very much. It's the intention to publish, and that's the first thing on the list. We will put together a protocol paper, because we do think it's, in terms of the level of detail and the how it's kind of being co-designed between sort of clinicians and Genesis and us at UTS. I think it's worth getting out there. So yes, we will have a protocol paper drafted this year, and obviously all the results will come out as they arise.
Great. I'll go back to Julia for this one. Would this, and this is probably particularly relevant because based in WA, would this bundled model work well for people in rural communities who want shared care between metro specialist centres and their more local community health programs?
Not the way it currently stands, because it's quite small in the way that we're providing it. It's based around St John of God Subiaco, so all the providers are within a small catchment, but over time we plan on expanding it to different parts of WA with different providers and different hospitals and things like that. So I do believe over time it will make a big difference and be able to join up those services a lot more than they currently are. We just are starting quite small to get the proof of concept right, and then plan on expanding further. The value of it is giving patients choice as well, to be able to access the providers that they would like to access within the bundle. So yeah, we really would like to be able to expand it and join up care as much as we can.
Awesome. Makes sense. Thanks, Julia.
And I think sorry, I was just going to say, you know, I think the presenters were chatting before the webinar started, and I think what Julia mentioned was that she now had a template, and I think that's the very right way to think about it, because obviously local circumstances and local inputs and availability matter a lot, but at least now there's a template that people can work towards, recognizing that, you know, there will be regional variation in how these things can get delivered.
Great, thanks, Kees. Well, look, we've got about 5 or 10 minutes left, so I'm going to finish off with a wraparound to each of the panelists on one of our most popular questions from the audience. It's not an easy one, but what do you see as the key barriers and potential solutions in Australia's health system in supporting innovative funding models? It's a big one, but like I said, very popular with the audience. And yeah, key barriers and potential solutions in supporting innovative funding models.
I'm happy to start if the other panelists.
That'd be great, Julia.
Okay, sure. I think it's data at the moment. I think data is the barrier and the solution. So the more we collect, the more we'll understand, and then we'll be able to potentially change the models to suit to adapt and create innovative funding models for bundling and things like that. We have bits and pieces here and there, but in terms of mapping the pathway against the costs for early stage breast cancer bundles, I don't think, and the outcomes for that, I don't think we have a holistic view of that, particularly in the private sector. So being able to collect that and really understand it, we might be able to see where the real functional barriers lie within the system, and then provide recommendations for improving it.
Great, thanks.
Shall I have a go next?
Oh yeah, go.
That would be excellent.
I mean, data, you're absolutely right, Julia. But I mean, also, I think I have to say we have the craziest health system in Australia. I think, you know, the divides that we have and the barriers that we've artificially put up. So I guess the key to that is that we all collaborate. And to do that, just make sure that you always put the patient in the middle of what you do, not the providers. This health system is not there to make the lives of doctors, nurses and administrators easier. It's there to make the lives of patients better. So we need to collaborate. But the technicalities I will leave to Sarah and Kees.
Yeah, I mean, I mean, obviously state, federal responsibilities. I mean, even that little project I mentioned is just how the PBS makes who's allowed to give out PBS scripts makes life really difficult for cancer patients, and nobody nobody realizes just the extent to which those two things that and I think that the willingness to innovate, and this is why it's been really exciting to be part of this project, and almost it almost had to happen outside of the public sector, and to have a large company take on that risk, because we do give America a hard time about they do have an insurance problem, but they do innovate, they do try things, they do try and break down those barriers and put things together, and so I suppose IPA's role in this is very welcome, and it's very, I understand it's challenging, but I would say definitely the willingness to give of the federal government and the state governments to give things a go in terms of loosening who's paying, getting less hung up about who's paying for what, and to see what works, and to trial it. Kees?
Yeah.
Right.
Okay. I agree with everything. And I think, I think what I can add to that is I think there's just always been a bit of a fear of change. And funding reform is change, and funding reform is particularly is a change of who faces the financial risk. So, what I think is unique, and where this pilot program is unique is how clever it is around implementing or at least starting to implement with a very careful examination of who and where those risk changes fall. And that, I think, is a key to get all the participants, all the stakeholders over the line to sort of get information, or give them information and reassurance that, yes, it is about risk, but those risks will be manageable on everyone. And as Chris, at the center of it is that patient outcomes will be better, because I think everybody will agree that the patient shouldn't be facing those risks, and that it should be divided amongst, whether it's in the public system and you've got state and territories and the Commonwealth, private health insurance, or providers, that those risks can be managed. And that's where I think the opportunity in that is exposed or illustrated by this pilot program is really, really novel, and things to look out for, because it does that sharing in a very clever way.
Thanks, Kees, and thanks to all of the panelists for your answers on that one. Look, it's been such an interesting discussion today, and an example of value-based care in practice, which is very few and far between. There's a lot of theoretical discussions about value-based care, and seeing the rubber hit the road is, incredible. And particularly a pilot that's been so carefully designed, and where the evaluation has been considered right from the beginning, is very much a rarity, both in Australia and internationally. Unfortunately, that's all we have time for today. I'd like to personally thank the panelists for your very interesting discussion, and I'm sure it will spark a lot of discussion with everyone who's watched it today. Also, thank you to everyone who took the time to join us this afternoon. And again, the panelists for sharing their insight and expertise. If you are able to stay online for a moment, I will spend a minute completing the survey that will appear on your screen. Although this is the final session in this webinar series, developing its next educational events program, and your feedback will help us to ensure we address the topics that are important to you. As Julia Hume mentioned at the beginning, you can stay up to date with the latest news and events by subscribing to our mailing list. The link to join this list is available on the IPA website, and we're also available on socials, in particular Twitter and LinkedIn. So thank you once again for your participation this afternoon, and enjoy the rest of your day.